Good morning and guten Tag from the UK. We would like to welcome you to the World Prurigo Day with over 625 registrations joining globally over 2 days of activities, both online and in person, over 9 countries and time zones throughout the world. We'd like to thank our sponsors, CSL Viver, Galderma, Sanofi Regeneron, and Incyte. Without their support, we wouldn't be able to run a global event like today. And the mission, we're working together to the care of prurigo nodularis patients. And World Prurigo Day, which we celebrate today, is a global initiative with a clear goal. We hope to raise awareness of chronic prurigo nodularis, advancing research and accelerating the development for new therapies. We hope through events like these, we will bring together leading dermatologists, researchers, and patients in one space. I'm pleased to say we have a strong UK presence this year with over 50 participants registered for today. We will have 3 talks presented by myself and my colleagues, and I hope we will have a very interactive question and answer session where we can better explore the UK approach to the management of nodular prurigo and chronic pruritus. I am joined today by Dr. Hannah El Hassan, who is a British dermatology resident. She has previously trained in London and Edinburgh and is now based in South Wales. She's led the UK's first evaluation of real-world use of dupilumab for prurigo nodularis and sits with me as the UK representatives to the EADV Pruritus Task Force. Beyond this, her wider interests include inflammatory dermatology and dermatology in patients with skin of color. After Dr. El Hassan, we also have Dr. Margot Niki, who is a locum consultant dermatologist at Barts Health NHS Trust in London and an honorary senior lecturer at Queen Mary University Hospital. Queen Mary University of London. She is actively involved in numerous European and UK organizations, and it brings me great pleasure to welcome her to speak with us on the treatment of itch, which runs along with her other special interests in inflammatory skin and hair diseases. After their 2 presentations, we will move on to a question and answer session. And please be aware, as this is a live streamed event to an international audience, we will not be able to answer personal clinical queries. But if you are a patient with nodular prurigo or chronic itch, I hope we're in a position to help you understand this complex condition better. So once again, good morning, and thank you for having me. I am Bernard Ho. I am a consultant dermatologist and consultant in lymphedema at St. George's Hospital in London. I have a parallel role in Epsom at St. Heliers Hospital and an honorary senior lecturer post at City St. George's University of London. In the next little while, I would like to talk to you about something that is, on the face of it, completely mundane, the itch. And I want to convince you that it is anything but mundane. Itch is the commonest skin symptom in medicine and the most measured, and arguably the one with the biggest mismatch between how patients suffer and how we treat it. This is a quick work on disclosures. This is current as of May, and I hold various advisory roles and ad hoc consultancy, travel grant, and sponsored talk arrangements with the companies listed here. Nothing on the slide is paid for what I'm about to say, but you should know it exists. I'll define what we mean by pruritus and the IFSI classification. We'll walk through the main clinical categories, show you how we measure itch in clinic and in trials, and spend a few minutes on the psychological burden and the itch scratch anxiety cycle, and finish off with where research gaps currently are. And why does this matter? In plain terms, itch is the commonest skin symptom. Almost everyone in this room has felt it. The problem is what happens when it doesn't go away. When itch lasts more than 6 weeks, it stops being a nuisance and becomes a disease in its own right and entity. In clinical and research terms, the numbers are arresting. Point prevalence in the general adult population is around 13.5%. The 12-month prevalence is 16.4%, and the lifetime prevalence is 22%. And when we translate that to everyone, it means roughly 1 in 7 adults are itchy right now, and about 1 in 5 will have a meaningful episode of chronic itch over a lifetime. The reason I want you to hold that figure in your head is because chronic itch produces a quality of life burden that is comparable to chronic pain. And this is in terms of mental health, in sleep, and also in functional impairment. I do have a pearl that I use with my trainees. Itch is the skin's pain, and like pain, it deserves to be measured, classified, and treated. So what actually is itch? The definition we still use is from Haffenreffer in 1660. He described it as an unpleasant sensation that provokes the desire to scratch. And remarkably, we have not really improved on this definition. There was an international Delphi consensus in 2024 that refined the wording, but the essence is essentially unchanged. The classification system most of us use is the IFSI, the International Forum of the Study of Itch. It is first time-based, so acute pruritus is less than 6 weeks. Chronic pruritus is 6 weeks or more. 6 weeks is the line in the sand, and it matters because the management changes completely on either side of it. The IFSI then divides patients into three clinical groups. Group 1 is itch on diseased and inflamed skin, so patients with atopic eczema, psoriasis, and urticaria. Group 2 is itch on normal looking, non-inflamed skin. In this group, for me personally, I always reach out for blood tests or further investigations. And, and group 3 is itch with a chronic scratch lesions, the prurigo nodularis phenotype. This is a useful clinical habit for our clinicians listening in, as every chronic itch patient should be tagged in your mind as group 1, 2, or 3 at the first consultation, as it does change your differential and management plan. The etiology framework I teach is around the six big buckets. So, one, dermatological, where the itch is driven by a primary skin disease. I've briefly mentioned earlier atopic eczema, psoriasis, urticaria, but conditions like scabies, lichen planus, bullous pemphigoid in the elderly, the skin usually can tell you the diagnosis. Secondly, systemic cause, so where itch is driven by internal disease, such as chronic kidney disease, cholecystitis, iron deficiency, blood disorders, the skin will often look normal, particularly in its early stages. Neurological being the third bucket, where it's driven by a nerve disease. Notalgia paresthetica, where you get an itch between the shoulder blades. Brachioradial pruritus on the outer forearm. You can get itch after a shingles or chickenpox infection. Or you can also get itch after a stroke or conditions like multiple sclerosis. You can also get mental health related itch, and we sometimes coin this under the umbrella term of psychogenic or psychosomatic. But more than often, we see a mixed picture where there is more than one cause running concurrently. This is very common in older patients and people with not prurigo pruritus, prurigo nodularis, where you may have an atopic background plus a neuropathic component, and there is also a mood driver to the itch. And lastly, pruritus of undetermined origin, PUO, where this is a diagnosis of exclusion. And these patients often do need reassessment because a third of them will eventually have an underlying cause. The pearl I want you to take away from this slide is if the skin looks normal but the patient is scratching, think about systemic, neurological, or mental health related itch and start investigating accordingly. Now to the consultation itself. When we do see patients describing their itch, sometimes this is quite useful to help link their presentation with the clinical data that we have. So by listening to the descriptor, it does sometimes point to the mechanism. When patients talk about itching and tickling, sometimes we think about a histaminogenic component. So we think about urticaria or drug-relating causes to their itch. When they describe burning or stinging, often I think about more about nerve-related problems. So postherpetic itch, brachioradial pruritus, crawling sensation. This is relatively non-specific. It comes under, it can be nerve related. It can be due to infestation or parasitic causes. Drug-related itch also sits within this parameter too. Prickling or pins and needles, I often think about small fiber neuropathy. And if they talk about a deep, gnawing, unreachable pain, we think about more about cholecystatic, so liver and gallbladder related itch, or uremic itch, kidney related itch. And the localization do matter. So a generalized itch affecting the whole body on a normal looking skin makes you think about a wider systemic issue. If it's a one-sided or dermatomal distribution, we think more about a nerve-related cause. The main point, however, is these descriptors are indicative and they're not diagnostic. So patients may have overlap symptoms, but the descriptor is a good starting point compared to starting with nothing. Now to the practical bit. If you don't measure it, you can't treat it. So for single item scales, we do think about using a 0 to 10 numerical rating scale, and that's the NRS. So this is a quick, validated, comparable with daily diary. The peak pruritus NRS, or the PPNRS, asks the patients to score their worst itch in the last 24 hours. And for Americans, this is an FDA-endorsed primary endpoint for itch trials. For multidimensional tools, we think about the 5D itch scale, the 12PSS, the Itchy Quality of Life, which is a disease-specific quality of life index. Um, and there are also the DLQI. This is a more of a generic tool. And there's also the PROMIS Itch Questionnaire. The Pearl and the minimum data set I would recommend for any chronic itch consultation is I would pair a intensity score, so an NRS score, with a quality of life score. So in my clinical practice, I do use a PPNRS along with the generic dermatology quality of life index questionnaire. And I do the two numbers every visit, and that's the minimum data set that I personally use in my clinical practice for chronic itch clinic. In the largest pan-European study to date, the Delgaards group, who published in 2020, dermatology patients with itch compared to dermatology patients without itch had an odd ratios of 2.6 for depression and 2.0 for anxiety. And the striking finding that they found was that suicide ideation in 15.7% of those with itch compared to 9.1% without. And in a smaller prurigo nodularis cohort, the suicidal ideation figure climbs further to around 19%. What's also worrying is that sleep disturbance is reported in roughly 90% of patients with nocturnal pruritus, so nighttime scratching and itching, and 60 to 80% across chronic pruritic conditions overall. And on the quality of life perspective, the dermatology quality of life index burden in severe prurigo nodularis consistently exceeds psoriasis. Severe atopic dermatitis flare is also comparable or higher than psoriasis. And the pro from this data set is chronic itch is on par with severe chronic pain and severe depression on every quality of life metric we have. So for the clinicians in this space, if your service is set up to take on chronic pain seriously, it should also set up to take up chronic itch seriously. This is the slide that I want you to most remember from my talk this morning. This cycle of stress and anxiety activates the HPA axis, which drive cutaneous neuropeptide release, releasing substance P, CRH, and these degranulate mast cells, which produces itch, and itch triggers scratching, and scratching damages the skin barrier and amplifies inflammation further. With more inflammation, it drives more itch, and more itch drives more mental health issues such as anxiety, losing sleep, and our mood falls. And this drives this ongoing cycle of itch, scratch, anxiety cycle. This is often a bidirectional cycle where the stress can also worsen itch, and the itch can also worsen stress. And we have evidence for both directions. Contagious itch is also exaggerated in atopic dermatitis, and this is a neurosignature of central sensitization in vivo. The interior cingulate cortex sits at the intersection of itch processing and anxiety processing. So there is a plausible shared therapeutic target, and there is an active area for trial design. The clinical implication of this means that if we treat the itch, the mood will improve. And we see this in the dupilumab atopic dermatitis trial as far back as etanercept psoriasis trials, where we also see a reduction in itch and a reduction in depression and anxiety score, with less tightly correlated with skin clearance than other endpoints, which suggests the mood benefit isn't purely the downstream of clear skin. And psychodermatology, and this is where my own clinical practice sits as a psychodermatologist, is we think of itch as the cleanest model condition for the integrated skin and mind care. The mechanisms are bidirectional, the burden is shared, and the therapeutics do overlap. The behavioral and psychological therapies that we do have evidence for, where we talk to tackling this itch scratch anxiety cycle is we talk about habit reversal therapy, and this is a randomized controlled trial grade evidence in atopic dermatitis. It reduces the scratching independently of skin disease activity, which is exactly the leverage point we want. CBT reduces itch intensity, anxiety, and sleep disturbance. We do talk about mindfulness stress reduction, as there are some small trials to suggest this does help in atopic dermatitis and psoriasis. And where we, as psychodermatologists, have access to is we talk about medications like SSRIs, such as serotonin, such as sertraline and paroxetine, as these do have evidence in the use of cholestatic itch. Duloxetine or other SNRIs are also helpful in this space. Mirtazapine has particularly good profile for nighttime itching, poor sleep, and also poor appetite. Sometimes we do think about low dose doxepine, but this has been phased out a bit in our clinical practice here in the UK. But from my personal experiences, the service model that works best for seeing our patients with chronic pruritus is a joint dermatology and psychiatry or psychology led service. And Psychodermatology UK has also provided some guidance around this. And the general pearl is if you cannot fully treat chronic itch without addressing the mind, you haven't fully treated the mind without addressing the itch. So there are tons of areas that we can delve more into the research gaps and the unmet need. But as a brief overview, thinking about the chronic pruritus of unknown origin or the PUO, patients with PUO, we may need to think about how we subtype these patients better, validating pruritus biomarkers, and but nothing from a lab-based setting have crossed into routine clinical use. As with other skin conditions, we know that skin of color is underrepresented in pruritus trials, and sorry, prurigo nodules do affect patients differently in different skin tones. We also need to think about more about itch in special population groups. And as we're seeing more AI and more digital health tools being used, it'll be useful to see how the digital phenotyping and digital tools are being used in this clinical space. But I do like to believe that itch is one of the few symptoms where bench, bedside, and behavior should be on the same trial protocol. So, in terms of red flags, my colleague Dr. Al Hassan will talk more about this. And Dr. Niki will talk more about the treatment landscapes, and that will be a very exciting sphere to listen to. So the take-home message from my perspective is chronic pruritus is a disease and not just a symptom. And we have, and in the context of where there is normal looking skin but a persistent itch, we should think about working up these patients systemically. We talked about the itch scratch anxiety cycle and how it's real, and the best management is integrating treatments for both the mind and the skin. And we also briefly talked about the research gaps that currently exists. Thank you for your time, and I will hand over to my colleague, Dr. Al Hassan.
Thank you, Dr. Ho. I'll just take a moment to share my slides. I check that you can see my slides in audience view.
Yep.
And it's moving.
Yep.
And you can see my laser pointer.
Yes.
Okay, perfect. So thank you. Thank you for the introduction. My name's Hannah Al Hassan. I'm a resident dermatologist or a dermatology registrar based in South Wales. It's a real pleasure to be here to speak to you on investigation of itch and its relevance. What I'm going to do is actually going to go backwards. So we'll start with relevance and finish off with investigations. I'm aware that we've got a rather varied audience, I think all the way from sort of lay members of the public to potentially world leaders in the field. So I'll do my best to make this as inclusive as possible. And given that it's World Prurigo Day and lots of us are particularly interested in Prurigo nodularis, I'll include some bits that are specific to Prurigo nodularis. I have no disclosures to declare. So, as I say, we'll start with the relevance of itch. So, the relevance relates to three aspects. Firstly, the impact on patients, and Dr. Ho has brilliantly covered this, so we'll just touch on that. Secondly, it's relevant to understand the mechanisms behind itch so that we know how to manage it. And linked to that, thirdly, the conditions that are causing it. So, in terms of the impact on patients, Dr. Ho has brilliantly covered that and has given a really impactful study illustration. But I also wanted to just share an additional meta-analysis and systematic review by a Chinese group that was done in 2024, particularly in relation to prurigo nodularis patients. So they looked at sort of essentially mental health impacts and endpoints in prurigo nodularis patients as compared to those without prurigo nodularis, healthy controls. So they found that patients with prurigo nodularis were approximately 1.33 times more likely to experience depression, nearly twice as likely to experience anxiety, and twice as likely to experience suicidality and thoughts of self-harm. So hugely impactful condition. In terms of the mechanisms behind itch, apologies, this is a rather busy slide, but from a scientific perspective, itch is very, very complex. And although this is a really busy diagram, this is actually just a simplified depiction of what causes itch. So for my non-medical attendees, we'll start off rather broadly. So essentially, the body has lots of different types of white blood cells, some of them shown here. And each of these produces a range of substances in the skin that you can see depicted here. And these substances trigger nerves in the skin, so the blue and the red, and they go through the spinal cord into the brain, where the brain processes these signals to create that itchy sensation. As scientists and clinicians, the substances in the skin are important for us because they form potential areas that we might want to target or develop medicines for. So you might be aware already of histamines from antihistamines that are commonly taken. And I'm sure later on you'll hear about some more specialized medications like dupilumab, which targets IL-4 and IL-13. For my medical colleagues, we know that within itch, there are two key pathways that are involved. So the histaminergic that's represented in blue here and the non-histaminergic that's represented in red. At the skin level, itch is transduced by a subset of A delta fibers as well as C fibers. And the nerve endings of these pruritoceptors are in the epidermis and the subepidermis. And they express a really diverse array of receptors for pruritogens. Within the histaminergic pathway, histamine is released from mast cells and basophils, and it binds H1 and H4 receptors on sensory C fibers. And then in terms of the non-histaminergic pathway, we now know that this is the dominant pathway in most chronic pruritus conditions, including prurigo nodularis. The literature and most of the research really focuses on what's happening here at the skin level and what's happening at the cortex level. But there's lots that's happening in a spinal cord level. Lots of signals are being modulated here before they reach the brain. And this is an important aspect to draw your attention to because this could form a potential future therapeutic target. In terms of what's happening specifically within prurigo nodularis, there are a few key players that we think about. So IL-31, this is 50 times more abundant in prurigo nodularis lesion skin, and it directly induces itch. It sensitizes the nerves and it causes even more nerves to develop to propagate that itchy cycle. IL-4 and IL-31 both stimulate keratinocytes. And then we have nerve growth factor. So this is markedly increased in prurigo nodularis lesions. It upregulates this capsaicin receptor on dorsal root ganglion neurons, and it causes even more nerves to develop. So it's a really major contributor to sort of peripheral sensitization. Apologies again, a rather busy diagram, but this essentially zooms in one further level and just shows you some of the molecules and receptors involved in itch. And I'm only showing this to plant a seed in your mind regarding treatments that my colleague Dr. Niki will discuss after me. So the key pairs sort of are important to us because they provide lots of targets for drug development. So we can target the cells that produce the itch-inducing molecules, or we can target the molecules themselves, or we can target the receptors that they act on. So, for example, we use antihistamines to block H1 receptors, or in the case of prurigo nodularis, as you'll hear about later, some of our treatments block this IL-4 receptor. IL-31 is another important target, and we have the capsaicin receptor, which also plays a role because this is where the nerve growth factor acts, as well as IL-31. Now, fitting this in a wider framework, we can categorize itch. And this is important because different mechanisms of itch warrant different mechanisms of targeted treatment. And Dr. Ho has already touched on some certain types of itch, but another way of categorizing itch, we've got pruritoceptive itch. So that's itch that starts in the skin, such as if you've got dry skin or eczema or an insect bite. You've got neuropathic itch, which is itch that's caused by a problem or damage in the nerves that carry the itch signals. You've also got neurogenic itch, which starts within the body or the brain without any damage to the nerves themselves. And psychogenic itch, which Dr. Ho has also touched on. So we know that itch impacts mental health, and mental health impacts on itch. And then usually, as Dr. Ho has also mentioned, we've got a mixture of these. So itch is usually caused by a combination of several different mechanisms, not just one. And Dr. Ho has talked about the itch scratch anxiety cycle, focusing on sort of the psychological aspect. But as dermatologists, we often talk about the itch scratch cycle, which is a vicious cycle of itch that our patients experience. And I think it's just worth explaining to patients in a simplified diagram like this how the cycle is perpetuated. So you've got an itchy sensation that drives you to scratch your skin. And then scratching the skin causes mechanical damage that releases more itch-inducing molecules. So, for example, histamine from disrupted mast cells. And the scratching causes also skin inflammation, which recruits more immune cells and amplifies the cytokine release. At the nerve level, chronic scratch behavior reinforces central sensitization. So you lower the threshold for future itchy signaling. And the scratching damages the intraepidermal nerve fibers, but also stimulates that nerve growth factor release. So you're getting more nerves put down in a dysregulated way, an abnormal epidermal re-innervation pattern. So you've got more itch being driven in a really vicious cycle. And understanding that biology explains some of the treatments. So we know that there are triggers for itch like heat or dryness or irritants and psychological factors. And we often give our patients therapeutic means of breaking that cycle. So if heat is a trigger, we often tell our patients to place a cold pack or an ice pack on the skin. And that cold will inhibit the capsaicin receptor. Barrier creams and appropriate clothing will counter irritants, and changing lifestyle behaviours to target psychological triggers is also really important. Finally, in terms of relevance of itch, we're going to talk about what itch can be indicative of. So there's loads of conditions that itch can be suggestive of, and these need to be identified so that we can give appropriate treatment. So, as I say, there's a whole host of skin conditions that cause itch. Itch is one of the most common symptoms that we see as dermatologists. And these are just a few of the skin conditions that are characterized by really severe itch. And we've got a photo there of prurigo nodularis. There are also lots of non-skin causes of itch. And it's really important for us to be aware of these because this will then guide and inform our investigation of itch. So, organ dysfunction, all sorts of organ dysfunction can cause itch. And just because there's itching in the skin, it doesn't mean that there's necessarily a problem with the skin that's causing it. Again, this is obviously not an exhaustive list. And then finally, there are medications that can cause itch. These are just some of them. So, when it comes to investigating itch, of course, the first thing that we do is we sit down with our patient and we take a history and examine them. And Dr. Ho has already spoken about how patients describe their itch and how that's helpful for us as dermatologists to guide our ideas about what potentially may be causing the itch. But in terms of our history, one of the key questions that we need to think about is, does this patient have itch with or without a rash? Because that's going to really importantly inform our investigations. Also important in our history, in terms of when what we're asking our patients, is it's really important to capture the psychological impact. So itch is, of course, highly intrusive. It's really distressing, and it's really important to pick up on these elements and assess them in as systematic and as objective a way as possible, so that we can further help our patients by getting them the appropriate help that they might need beyond the dermatological needs. And Dr. Ho has already mentioned the importance of using validated scores. So validated scores to capture that itch are important for us as clinicians because they help us track our progress in a standardized way over time. Is our treatment helping? How is the itch progressing? And within a clinic setting, I think probably the most practical tool would be peak pruritus or worst itch score. So it's well worth sort of including these in our clinic letters and our notes. Now, in terms of investigating the itch, as I mentioned earlier, itch on normal appearing skin is going to warrant a more aggressive systemic screen because we're thinking about some of those non-skin causes of itch. Organ dysfunction. So we mentioned in the earlier slide that abnormal kidney function or liver function can cause itch. So we often think about doing a kidney profile or liver profile or an endocrine profile, depending on what our patient has told us. And we're not necessarily going to do all of these investigations. And these investigations are really going to be guided by our patient's history and their examination. We may or may not take a sample of skin to look at it in more detail under the microscope. There are some red flags that we need to be mindful of and to think about. So, for example, if we've got a slightly older patient who's coming with unexplained itch and weight loss, for us, it's often a red flag to exclude malignancy. So, a detailed examination, feeling for lumps and bumps, thinking about getting imaging, thinking about appropriate blood tests. That's waking up our patient at night. We're thinking again about certain types of malignancy, but also scabies, really itchy condition. Academic itch without a rash. We're thinking about myeloproliferative disorders and polycythemia vera and doing certain blood screening for things like that. One-sided itch, Dr. Ho has mentioned, or dermatomal itch. We're thinking about cervical myelopathy, getting imaging for spondylosis and things like that. And again, as Dr. Ho has mentioned, really severe itch that's prompting thoughts of self-harm or suicidality in our patients. We need to get the urgent mental health input and putting in place appropriate safeguarding for our patients. And of course, there's chronic non-parasitic infestations to consider as well. These generally are going to require a multidisciplinary team discussion and approach. So this is what we've talked about. Itch is really impactful on patients' lives. And so it's really important for us to understand what drives it. This isn't just a matter of scientific curiosity. And understanding the mechanisms and causes of itch will go hand in hand with appropriately investigating and treating it with precision. And I believe that's what you'll hear about next in more detail from my colleague, Dr. Niki. Thank you for listening, and I'll look forward to discussions later on.
Thank you.
Bernard?
Yes. Do you, how, so I think Margot's running a slight technical difficulty on her end. If we might just need around a few minutes.
We
In
could
the in
start the discussion in the meantime, I think.
Yeah,
And
okay.
yes, let's try to sort that out, okay? Thank you.
Yeah. So, I guess, Hannah, whilst we're sort of waiting for some questions to come in, as we haven't formally reached our Q&A session, I guess, um, Hannah, what do you feel as a trainee? Um, what is, uh, what have come across your revision around itch that has been most striking for you?
Not from a revision point of view, but from a sort of a clinical practice point of view, it has to be the impact on patients' lives. Sort of, it's such a distressing symptom to have, and particularly when we're reaching those chronic levels of sort of six weeks plus. Um, it takes over patients' lives, and I think that's why being sort of things like World Prurigo Day, bringing about sort of an understanding of the importance of that is really really important. Of course, sort of ploughing into sort of the research and developing appropriate treatments, and certainly when we do sort of get our patients on treatments that are working, I think the most striking and impactful thing that I've certainly experienced in my clinical practice is just the life-changing impact that this has on patients' lives. From abject sort of dysfunction to being able to live again.
Hmm.
I think that's the biggest factor.
I completely agree. I sometimes this contagious itch, isn't it? When we talk about itch, we as clinicians, when we see our patients, we also develop this feeling of itch in clinic. And it's such a relatable symptom, isn't it? And to know that, I've got bitten a few days ago and I'm still scratching away. And it's in your forefront of your day-to-day activities. Um, so I think, most I would say every dermatologist would have experienced itch. And I do think it's one of those symptoms that we can relate to our patients, um, and um, and appreciate that it can be overwhelmingly consuming for some.
Yeah, it's ethnicity as well. It's how long sort of often it takes to sort of for sort of in terms of what patients are experiencing. Of course,
Mm.
there's sort of it takes a while to get to see a dermatologist. All the
Yeah,
meantime, they're sort of suffering away. And even when they do see us, of course, we have to run our investigations. That all
yeah,
takes time. So yeah, no, it's hugely, hugely impactful.
yeah. And in the absence of a magic cure for pruritus, um, we do ask a lot for of patience from our patients and from our service users, don't we?
I think we're all sort of cognizant of that as well.
Mm.
But it doesn't make it any easier, does it? It doesn't make it
No,
any.
no, particularly with the waiting times to see us, at least in the UK, which, I have seen patients have waited a year for their appointment with, not with me specifically, but with the service. It's been taken. Um, so by that point, their itch is definitely chronic and definitely long term. Um, so we do have to reach for therapeutic options, um, where our primary care physicians don't have access to. Um, have there been any tips or anything that you want to share with our patients as to what you found has been helpful hearing from other patients with chronic pruritus or nodular prurigo? I quite like the ice pack mention
Yeah,
that you've suggested. Some of my patients do get, there is this temperature related, and by changing that temperature, perhaps that C fiber activation, which we do see with menthol cream, for example, it activates that C fiber. That may play a role in helping itch. What other tips or tricks do you have up your sleeve?
Think it's anything that helps break that cycle, because really it's the
Mm,
cycle that's the problematic thing. I mean, sort of you've got something that's causing the itch, but once you're itching, you're really driving things. And as I mentioned, the nerve growth factor, and sort of you're sensitizing yourself by scratching. So anything that breaks that cycle is going to be
mm,
helpful. So ice packs or sort of other means of cooling down the skin, like menthol cream, moisturizing the skin. I know
mm.
it's not sort of, depending on, it's often quite difficult to find an emollient that patients get on with and like,
Yeah.
but it's trial and error. It's absolutely trial and error. There's an abundance of emollients out there. And I often send my patients away with lots of different samples, little samples, so that they can sort of find something that suits them, and then they can get it sort of whatever they like can be re-prescribed by their GP. Um, Moisturizing skin is certainly not to be
Yeah.
underestimated. Distracting yourself as well. I know itch obviously takes over, can take over thoughts. But again, it's what you mentioned, that itch scratch anxiety cycle. If we can at some point break that,
Mm.
distracting yourself, so you're not sort of focusing and becoming even more consumed by that sensation, can be helpful. Is there anything that you've found in your practice that
I
you've
quite like a fidget spinner. I like the for
mm,
patients with ADHD and neurodivergence, um they do sometimes present to me with fidget, those toys that they can very tactile toys and gadgets, and I've used them I suggested them to patients with this itch scratch anxiety cycle, and it helps them, just having something to do with their hands rather than scratching away. I also quite like the steroid infused tape or the steroid infused dressings because it does provide occlusion to the area, and also when patients are scratching, they're not damaging the skin. So you're breaking the cycle, but not in a way that still allows patient to still scratch themselves. Um, so I do quite like those as adjuvant options, as we sometimes do talk about systemic treatments to go alongside topical treatments to go alongside their systemic treatments. I also quite like fridged emollients, so because menthol can be quite strong, and a caution to anyone who do have asthma, using inhaling strong concentrations of menthol can trigger asthma. So be cautious of that when you're prescribing menthol-based moisturizers. But I do like it comes in different strengths, 0.5, 1, 2, and 5. Those are the concentrations we have accessible in the UK. Um, and uh, using uh, using that as one option, but putting our moisturizers in the fridge, particularly if they have one that they quite like. I like having one in the fridge and one in room temperature. That gives the flexibility to our patients with chronic itch. So I live by my practice. I always have a tub of moisturizer in the fridge, and if it's um, really warm or really itchy, you can pull that out, and it's quite a. I do like the gel formulations for that particularly. Um, what else? And oh yeah, mo moisturizing the back. Do you have any tips, Anna?
gosh, I've encountered all sorts of contraptions actually.
Yeah, what have
Um,
you seen in clinic?
DIY tools
Yeah, yeah,
essentially.
yeah, 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 yeah.
DIY tools, sort of almost a DIY sort of paint roller.
Yes,
Um,
I've seen a paint roller being used too.
whatever you can get, so long as you, yeah, I mean, and to be fair, if you're not able to reach an area of your back to scratch it, hopefully that's sort of a means of sort of reducing that, nerve fiber sort of propagation.
Yeah.
Um, but no, a really, really uncomfortable sensation. Essentially, DIY tools are sort of what I've encountered in practice. If you've not someone to hand to um to do it for you.
Yeah. I think that's one of the hardest bits. So I think I do see spray emollients being more used now. So there are spray emollients I've designed so that you can tip it over and it still sprays and works. That's quite helpful for that uh, for uh, for the itching between the shoulder blades.
I love a spray
And
emollient generally, especially for children. I think
yes,
they tolerate it a lot better.
and it also ha provides that immediate cooling sensation just from the spraying itself. Um, but yeah, we do see little pads that you can buy where the pad is stuck to a stick and you use that sort of rod and it just allows you to apply the moisturizer quite easily.
Now that's great. So thank you very much for this wonderful discussion, actually. A lot of technical difficulties today, but we are very happy. If it was in person, I would do it without slides, but since we are virtual, I tried my best because all my pictures got deleted for some reason. They were not seen on my presentation suddenly, but anyway, here we
It's
are.
all
I'm
good.
very, very excited to be here with you. After these amazing presentations from my colleagues, we're going to focus on the management and the various treatment options that we have for pruritus. So my name is Margot Guinea. I'm a consultant dermatologist at Bars Health and an honorary senior lecturer at Queen Mary University. I have a special interest in inflammatory conditions. And today we are very, very excited and we are very happy to participate as the UK team at the World Prurigo Day. And this is a significant event because until now, pruritus and prurigo have not been addressed as they should. And we know that our patients have been suffering. So here are my conflicts of interest. I'm sure you're not very interested in them. And as my colleagues already presented, itch or pruritus is one of the commonest symptoms that our patients present with in our clinics. And apart from being one of the commonest symptoms, what happens is that it's one of the most debilitating one. Why? Because it has a significant impact on mental health, on the quality of life of patients, but also in their general well-being. Imagine being itchy all day and all night. You're not able to sleep. You're not able to work. You're not able to go to school. You're not able to focus. It can affect your relationships. So it really affects all the different aspects of life. And here we're having a quick look at the pathophysiology of pruritus. I'm not going to go into a lot of detail, but I'm just going to focus actually on some specific cytokines that are implicated in the pathogenesis of pruritus and conditions like nodular prurigo. So that's why we're going to cover some of them a bit later. So the question is, yes, we said it has a significant impact. The impact is massive. We try to support our patients. Yes, we need to do a lot of investigations. Actually, why? Because our investigations are needed in order for us to understand what is happening and what is the cause behind the pruritus. But the reality is, what do we do in real practice? The reality here is that give me 1 second. Let me just go back to the presentation mode. And we have the European guidelines actually that are very, very helpful because they guide us what to do. So we have systemic conditions, first of all, that can cause pruritus. So they are already covered. I'm not going to go into a lot of details. There are also drugs that may induce chronic pruritus. Here we should have a list, but unfortunately the list is not appearing. But always, when you have a patient with pruritus in front of you, you always need to ask them what drugs they are using. And yes, we mentioned the psychogenic pruritus, but I'm focusing a bit more on that. Why? Because we have a special interest in psychodermatology, and we have here also our clinic at Royal London Hospital, where we are treating patients that have been affected because of their pruritus from a mental health point of view, but also patients who are coming because they're very, very itchy, and we're trying to offer them an holistic management. And of course, we are having some common dermatological conditions. So we have psoriasis, and I'm mentioning that as first, and the reason is that psoriasis historically has been supposed to be a non-pruritic condition. So when you are looking at the different books, you will see that psoriasis is not considered a very pruritic condition, but this is not true. We know very well now that psoriasis can be also itchy. We have other conditions like urticaria. And last but not least, we have atopic dermatitis and nodular prurigo, extremely itchy conditions. The burden is massive. I would say that approximately 95% of the patients, there are many different studies out there showing that the patients are itchy when they're suffering with these dermatologic conditions. So it is really, really important for us as dermatologists to see this patient in a specialist clinic, in a specialist setting, and take it from there. So again, what do we do? Before we do anything, yes, somebody comes to us and they are saying that they're itchy. But the reality is that we need to assess how itchy they are. So already we mentioned some of the different scores that can be used. Personally, I like these linear itch intensity scales. They're very simple to use. We have the numeric rating scale, which I find the most practical one. So from 0 to 10, you ask the patient, how itchy you are. 0 means no itch, 10 means the worst pruritus ever. But apart from that, we need also to understand the impact of this pruritus on patients. So we have questions like DLQI. We're using that a lot in dermatology, but in reality, it's not a very specific questionnaire, but it gives us a rough idea of how patients are doing. And then we have other more specific ones like the itchy quality of life. We have also, other ones like 5D or PBIP. And at the end of the day, I think we're doing that more in research, so not so much in our clinical practice. I think we're going to do that in the near future because we're using many more digital tools, and we are going to use more digital tools in our clinical practice. So there are specific apps, so patient is able to provide how they feel, how itchy they are, and then we can have a better idea of what has happened to them during the last few days, the last few weeks, and it's not just a specific moment, a specific time point. So now moving on to treatment. Yes, we saw the patient, we diagnose what is the cause, what is happening, how itchy they are, but if there is an underlying cause like the previous ones that we mentioned, somebody, for instance, may be diabetic, somebody may have they may have uremic pruritus. So we need to address all of this. We need to find out the underlying cause and try to treat it. And normally this is happening for these systemic conditions that cause pruritus, and we need a more of a multidisciplinary approach also with other specialties. Otherwise, what we are offering to everyone who is itchy, we're offering some general measures. So first of all, we need to offer them some soft clothing. Cotton is always one of the best options. We need to offer them moisturizers. We need to offer them lukewarm waters. Not baths that are exceeding, that are really, really long, that are like half an hour or 1 hour. We need also to inform our patients about factors that they should be avoiding. And they are contributing more to dry skin that can cause further itch, further pruritus. And of course, we mentioned that stress can play a significant role on pruritus. So that's why we need to have some relaxation options. So this can be, from habit reversal to yoga or other options that will make patients feel calmer. And of course, we need to educate our patients. There are many different schools that can be available online. There are also, many pruritus schools that are organized in different departments, and patients can understand better their condition, what they can do, and what they can avoid, and how they could potentially contribute to becoming less itchy, although this is not always the case. And this is always a reminder that we should have to our patients. So when you're itchy, it's not your fault. So definitely some factors may contribute to that, but it's not the patients that are doing something. And we need to address that because many of our patients are becoming extremely anxious about that. And the reason is that they are feeling that perhaps they could do something better. Otherwise, we need to eliminate the aggravating factor. We mentioned that. So always moisturizers, cool environment, avoidance of skin irritants as much as we can to reduce the stress. And sometimes, occlusion. So using some patches in specific areas that can be, quite excoriated, they can be very, very helpful. And yes, what we are trying to do with the different treatments that we have is to break the itch-scratch cycle, which can be a vicious circle, and sometimes it can be very, very hard to treat. And sometimes antidepressants can be quite helpful in the management of pruritus. And again, here, a kind reminder for all of us as clinicians, but also to patients suffering from pruritus, because there is still stigma surrounding the prescription of antidepressants for the management of pruritus. So the reason that we are giving these medications is that actually they can work very, very well in various causes of itch. So yes, in some cases, we can prescribe antidepressants in patients who have itch and they have developed a secondary depression or anxiety because of their itch, but also some of them, they may work also on specific mechanisms of itch. So there should be no stigma. We should all be a bit more open. We should embrace this type of treatments in our practice. And yes, we have some topical therapies. You can see here in a table some of them. So definitely moisturizers, some topical steroids can help sometimes, but this is not always the case. Menthol I find quite helpful because it provides a cooling sensation to the patients, and many of them, they are very, very happy when they're using menthol. And I would also mention capsaicin. These are two of the treatments that I'm using in clinical practice, that I'm using in my clinic. And capsaicin, although it is supposed to work better for the neuropathic itch, sometimes when it is very, very localized, it can be extremely helpful for some patients. And here we have an overview of the systemic therapies for pruritus. So if you ask any patient with pruritus, have they ever been prescribed something like antihistamines? All of them, they will say to you that, yes, we have been prescribed. We're getting also higher doses of that. But the reality is that they may not have a significant impact on pruritus apart from that is related to urticaria. And sometimes sedating ones, they can be a bit helpful. And the reason is that patients may be a bit more able to sleep. Otherwise, we mentioned the antidepressants. Then we have the opioid receptor antagonists like naltrexone. Yes, it can help, especially in some cases like the cholestatic pruritus or the CKD-associated pruritus. We have the kappa opioid receptor agonist. We have the selective kappa opioid receptor agonists. Often we are seeing that patients are being prescribed anticonvulsants like gabapentin or pregabalin. These are more related to the neuropathic pruritus rather than any other conditions. And for prurigo nodularis, we have medications like thalidomide that actually can help, although to be honest, I don't think we're using that so much anymore. We have been using that until recently because we didn't have too many treatment options and some patients were very severe, but I wouldn't say that we're using them so much. So here we are looking at the International Forum for the Study of Itch. So here is a guideline. And we are seeing the treatment ladder in nodular prurigo. So we're talking a lot about chronic pruritus and chronic prurigo, but nodular prurigo seems to be one of the commonest actually cause of nodular prurigo. And at the moment, we are focusing a lot more because we have more treatment options. So yes, we have the classical steps, as we mentioned before. Everything goes as a step. I would like to mention the cyclosporin and methotrexate because in some patients it may work. And when we are looking at the final step, yes, we will do the topicals, yes, we will do the capsaicin. Sometimes the phototherapy may be useful. Gabapentin, pregabalin, antidepressant, cyclosporin, methotrexate. Here we have the receptor antagonists that we mentioned before. And last but not least, we have advanced treatments like dupilumab and nemolizumab that have been approved for the management of conditions like nodular prurigo. In the UK, they are not reimbursed, so we need to remember that. But we will see what will happen in the near future. So my point is that there are more treatment options. And no matter what we say as clinicians, what matters at the end of the day is the patient journey. And looking at the patient journey, it can be quite long, it can be quite stressful, it can be with a significant impact on our patients' lives. And that's why when we are prescribing a treatment, what we need to remember is to see that if this treatment works also for the patients. It's not only us that we're saying, okay, hopefully this will work for your itch and it will improve your symptoms, or this will improve your nodular prurigo. The reality is that the patient should be the center of our care. And apart from that, we are looking also at another condition, which is atopic eczema, which is a very pruritic condition. And here you're seeing the European guidelines that include many advanced treatments. So we have JAK inhibitors, we have also biologics, and some of these actually, they are also approved for the management of pruritus associated with atopic dermatitis. And yes, we mentioned nodular prurigo before, and we are very happy because here in UK, we have the BAD guidelines for nodular prurigo that were published recently, and they are coming, they're very, very close also to the American guidance that we have. So this is a very practical and algorithmic approach. So we're seeing topicals, we're seeing phototherapy, we're seeing systemics like methotrexate and cyclosporin and thalidomide. And yes, dupilumab and nemolizumab should be offered for patients who have conditions like nodular prurigo and they're moderate to severe. And here you can see a bit more graphically the two biologics. So we have dupilumab and nemolizumab. So dupilumab works by blocking IL-4 and IL-13 here. It's not very, very clear. And we have also nemolizumab, who is targeting the IL-31 receptor. And we have clinical trials, both for atopic dermatitis, but also for nodular prurigo. The results are very, very encouraging and exciting. And we are also, a bit happier as clinicians because we are able to offer more treatment options, which can be effective, which have an acceptable safety profile for our patients, and at the end of the day, help our patients. And here we have also some systematic reviews coming out with assessing many more treatments involved in the management of nodular prurigo. And for instance, in this systematic review, we had various treatments compared, like phototherapy. We had also conventional systemics and dupilumab that proved to be quite efficacious and safe. And why I'm mentioning the Swiss practice recommendation from chronic for nodular prurigo and chronic prurigo, because there is more awareness now, and we're seeing more and more groups all over the world are working towards how to manage chronic prurigo. And looking to the future, there are more treatments that are being discussed in terms of pruritus. We have JAK inhibitors. We have a treatment called serlopitant. It hasn't done so well in terms of nodular prurigo in phase 2 clinical trials, but we will see what is happening at the end. And the future looks more bright. So I would like to finish a bit more with an optimistic approach Yes, we have treatment options in our armamentarium, and I would like to thank you very, very much for joining us today in the World Prurigo Day. I apologize again for the technical issues, but at least we got some pictures and some slides. And, Bernard, the floor is yours, actually.
Thank you so much, which brings us quite neatly to our Q&As. So, I thought we'll start us off with some questions to ease us in. I thought we'll start some common questions I do get in clinic. So do diet changes or supplements actually help with chronic itch? What
That's
are
a
your
very,
thoughts and views?
can I reply?
Yeah, go for it, go for it.
Yeah, so have I stopped sharing my screen? I
Yeah,
think
yeah, yeah,
so.
yeah, yeah,
Okay,
yeah, yeah.
wonderful. A very, very hot topic, I would say, and a very common question by the patients, because it's this category of patient that we mentioned that they are trying to find a logical reason behind their pruritus. So they're just trying to think if there is something that they could eliminate from their diet in order to see if this is going to have an effect on their age. I wouldn't say that we have robust data, so we don't have something really robust to say to patients, okay, you should avoid this and that. There's a lot of discussion around diet and the inflammatory properties. We have seen a lot more studies actually in terms of diet and conditions like pruritus or psoriasis or atopic dermatitis. But the reality is that we need more data and more advice.
Yeah. Hannah, do you have anything else?
Yeah, no, agreed. To the best of my knowledge, there isn't anything in terms of diet that contributes to, causes, or exacerbates. But I think when someone's asking that question, it probably gives an indicator as to how much the itch is impacting them. That they've got, I've had a plethora of patients who've eliminated all sorts of things from their diet, dairy, meat, to the extent where they're living on, it's questionable what they are living on because
Yeah,
they're just eliminating everything in the hopes of getting something that will make their itch better. So I think the question itself, when it is raised, is an indicator suggestive of quite how much this patient is suffering with their itch. And yes, I would give the brief answer that unfortunately, there's nothing in the evidence base that suggests that, but
yeah.
really sort of focus on the overall impact, the psychological impact that this is clearly having on them, as well as actually the added impact of them trying to remove all of these things and worsening their quality of life in an added way.
Yeah, I echo that point. I do see some patients with the antihistamine diets that seems to be on vogue right now. And actually where patients who or people who do exclude a lot of important nutritions in their diet, often it can cause secondary skin problems due to nutritional deficiencies. So I do have to then do not necessarily trace elements, but B12, folate, iron to look for deficiencies that we then need to supplement whilst telling patients to go back on to reintroduce the food groups, particularly where we know, as both Hannah and Margot have demonstrated, a lot of the itch is not a histamine-driven process. So a low histamine diet is not necessarily going to help with their itch.
Exactly. And the point is that that's why also antihistamines do not work. And
Mm,
also these antihistamine diets, they are so, so limited. So personally, because I have seen these diets and, the reality is that I think they affect also patients a lot more mentally too in their attempt to
yeah,
try and avoid all these things.
yeah,
I would just like to make a comment, not so much about the diet, but I would say, about the treatment landscape. One common problem that we are all seeing in our clinics is that many of our patients with chronic pruritus, many of our patients with nodular prurigo will appear in our clinic many, many years later. and they have been suffering for years, actually. Not enough treatments have been offered to them. Many of them, they have no clue about what is their condition and what is happening. So what I think is really, really important, and that's why we're very excited with these initiatives like the World Prurigo Day, because we need to raise awareness. We need to raise awareness among us as clinicians. So as dermatologists, as nurses, as general practitioners, we need to be aware about pruritus, and we need to be aware about conditions like nodular prurigo. Also, we need to be aware that now there are treatment options, because many of our patients, they have kind of disappeared. So looking at our, lists over the period of years, we're seeing that many of these patients, they are not coming to see us anymore, and they are somewhere suffering because at that time they were told that, look, I don't have any more treatments for you. So that's why it's really important to raise awareness among us. It's really important for general practitioners to refer our patients earlier. So some years ago, we had done an analysis from our nodular prurigo patients at Royal London Hospital. And what it was shown is that the majority of these patients, they had a really long course of the disease. And this long course of the disease was a negative prognostic factors in terms of their management. And yes, we offered holistic management. So Bernard also has a special interest in psychodermatology. So we are trying to offer an holistic approach to these patients, apart from the classic conventional systemic medications that we give or biologics. But the reality is that the longer the disease is there, the harder the condition is to treat. So a key message from us today should be that, yes, there are treatment options. Yes, patients should be referred earlier because they will get a treatment that may help. Okay, in UK, in terms of NICE, there is an issue with the reimbursement, but hopefully we will have some more options. And there are a lot of clinical trials too. So many new medications that are trialed for patients with chronic prurigo or nodular prurigo, or chronic pruritus of unknown itch, which is another entity which is quite challenging. So
So on that
remember
note, because there are some questions around accessing treatments, and you've kindly alluded to that, Margot. What are your thoughts around and having seen through those guidelines that you've presented? Um, we do have a varying experiences in how we are able to access those high cost drugs within the UK. We have different guidelines between Wales, Scotland, and the UK. What are your views on that, Margot? And then I'll go to Hannah because she works in a different area now compared to us.
Exactly. So as you say, unfortunately, here in UK, we have this, what we tend to call postcode lottery. So depending on where you live, on where you are, there is different access to various medications. So, for instance, in Scotland, for instance, one of the biologic agents, it is NICE reimbursed for conditions like nodular prurigo, while, we are here in London and we don't have this reimbursement. So I think what should be done, and what is done by a lot of our more senior colleagues, I would say, is that we need to put more pressure. We need also more support by the manufacturers of the different medications, because this needs to go through the NICE approval. NICE is, I would say, a very standard procedure. So all our medication, and especially the high-cost drugs, they're all undergoing NICE review in order to be reimbursed for patients within the NHS. So what we should be doing is raising awareness again about that, showing the significant impact of these conditions. So there is still a theory, and I think in many people's mind, that it's dermatology, it's just a rash, it's itch. Is it true? No, it's much more than that. And that's why we as clinicians, we need to raise awareness towards that, to stakeholders, to other clinicians. We need to raise awareness to NICE about that. We need to push more. But I think that the field, in terms of conditions like nodular prurigo, which have not been discussed so much, will be more promising in the near future. and in the longer future. Because the patients are there, we don't have very good prevalence studies to see how common this condition is, because, as we mentioned, many of these patients, they are not appearing in our clinics, and I think we need more robust data in terms of the
Yeah, so
prevalence.
I think the statistics, suggest 1 in 7 will develop itch in their life, will present with itch.
Yeah.
So that's quite, I think, high enough of a statistic. And I think, like you said, yeah, we should be applying pressure, particularly. So for those who don't know, so although UK includes Wales, Scotland, and England, they all use different. England and Northern Ireland is one area. They all have different ways of assessing whether treatments will be approved in their devolved nation. So, in England and Northern Ireland, for example, where we based a lot of our funding on the NICE recommendations, this high cost drug, for example, dupilumab, has not been accessible for our patients in England and the Northern Ireland for nodular prurigo specifically. It is still remains licensed for other health conditions, and where patients who have nodular prurigo and a separate health condition that allows treatment with dupilumab, we do see patients who do respond well from a nodular prurigo perspective, but that tends to be a more secondary benefit. Whilst in Wales and Scotland, they do seem to have access to dupilumab. And I'll signpost to Hannah, who is currently working in Wales, to see what her experience has been.
Yeah, so in Scotland, which is where I worked
Oh, yeah, sorry,
initially,
Scotland. Yeah, yeah.
fine. So in February 2024, the Scottish Medicines Consortium approved dupilumab for the treatment of moderate to severe nodular prurigo. So what Margot sort of alluded to in terms of a postcode lottery within the UK, essentially we have an evidence base for this medication. So there was a randomized control trial, Prime and Prime 2. That looked at treating nodular prurigo specifically with dupilumab. This gave some evidence that, fairly robust evidence, I would argue, that nodular prurigo in moderate and severe forms responded very well to dupilumab. The variation comes in the bodies that then approve financing for medications like dupilumab. So NICE in England looked at that evidence and said, actually, we don't think that this evidence is robust enough to give a case that this is a financially viable option in the UK. And so they said, actually, we're not going to finance dupilumab. But in Scotland, the Scottish Medicines Consortium looked at it and said, sort of that same sort of trial data, and said, actually, no, this is enough for us to pay for this medication for our Scottish residents. So in Scotland, we had access to dupilumab for moderate to severe prurigo nodularis, and it was a wonderful medication to have at your fingertips, because nodular prurigo, I think we all know, and we've all sort of really emphasised, hugely, hugely impactful. And I sort of looked at sort of the real world evidence of sort of treating that in our centre and an additional centre in Scotland. And life changing is kind of sort of the phrase that I was commonly hearing, but it didn't work for everyone. And I think that's something to be mindful of. It didn't work for everyone, and there is reason for why NICE has not yet financed it. It's not to say that we will not have access to biologics. There are lots of biologics going through sort of NICE panels, as Margot and Bernard have both alluded to. But yes, there is variation in the UK, and sort of I've kind of briefly explained why there is variation in the UK.
Yeah, I think your point exactly is that even though we have these medications that are new, it's not everyone responds to it. And I still reach out to methotrexate, cyclosporin, these more traditional medications. And I have a few patients on these opioid antagonists where clinically appropriate. These are a lot cheaper for the health system, but they work, provided patients are happy to navigate these medications. And I think old school phototherapy has a role in place for our patients with chronic pruritus and nodular prurigo, and combination treatment works quite well, where you give them a systemic and then you also refer them on for phototherapy. Yes, it is time consuming for our patients, but if we can get the timings of the appointments right, we do see significant improvement in their itch and their nodular prurigo, um, uh, and and we're able to monitor them where we don't necessarily get to if they weren't having phototherapy, for example.
Yeah, I
I think
completely
that's
echo that. That medicate that sort of are sort of more classic systemics. Sorry, Margot, to sort of interrupt. Are more
no, 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 you're
classic,
fine.
Margot, are more classic sort of systemics are still effective. I would sort of highlight that,
Mm.
and also with with these new sort of novel medications, you know, we can't, unfortunately, because they've not been on the market long enough, tell patients what the long-term impacts of being on these biologics are. I can't tell you in 50 years' time what side effects or implications you may or may not experience, but I can fairly confidently tell you about methotrexate because it has been around for that long. Sorry, Margot, please go ahead.
Yeah, so yes, I definitely agree that some of the conventional systemics, yes, they may work in some patients. Nevertheless, I think because I have practiced also, in other countries abroad, I think the patients need to have access to advanced treatments a bit earlier. We have, robust studies for dupilumab. We have for nemolizumab too. Two of the medications that have been approved but not reimbursed. That's the difference because at least in England, for conditions like nodular prurigo. So yes, we are open to some other medications. We're open to the conventional systemics because we have been using them for years anyway, because we didn't have any other treatment options. But the newer treatments, the more advanced treatments seem to be much more targeted. So in terms of safety, we have seen, very acceptable safety profile. We have been using also these drugs for many years now. So looking, let's say, back to dupilumab, it has been available in the market, at least for atopic dermatitis, since it's almost 10 years now. And if we take also the trials behind, we're talking about a very long period of time. So I wouldn't be concerned, I would say, in terms of the safety, and I wouldn't discourage patients to go ahead with an advanced treatment when they have nodular prurigo and instead say, okay, if I had the option, you can carry on with methotrexate because it has been available, for more years. I think, we're talking about more targeted treatments. We're talking about precision medicine. We're talking about personalized medicine in general.
Mm.
So yes, these treatments are targeted. They are efficacious. Definitely, we need more real-world experience. There is already real-world experience from other countries, and we need them in our hands in order to support our patients, because yes, a percentage of our patients are doing well on conventional systemics, but also a large percentage of our patients are not doing well, and we don't know what to do with them. So we need to look ahead. We need to put pressure. We need to work with our patients towards that direction. We need to offer an holistic approach. And what else I wanted to say is that, yes, we are talking about cost and cost and cost in UK. We don't see that so much in other countries, and this has to do again with the nice approvals. But at the end of the day, we need to look at the value of the drug. So cost is just a price. Yes, it's the price that you can see on an injection, on a pill, but looking at the value of the drug. So if we look at a drug that may be a bit more expensive, but in reality, it prevents the patient from developing all these psychosocial comorbidities. It makes
I
the
think
patient.
prevent is quite a strong word, though, Margot. I'm not sure we
Sorry?
have I think preventing psychosocial impact from
Yes,
it
preventing.
is
Okay,
quite a
it's a very strong.
strong
It's a very
statement to
strong.
make in this
Yes, it's a
context.
very
Yeah.
strong. I agree, but let's use a different word. Let's say that some of our patients, if they were treated early, they would probably some of them they may have had less comorbidities, because all these comorbidities are accumulating over the period of time. And the
Yeah.
cumulative life
So
course
I
impairment,
think we can all agree on in this space that early treatment is important. And I think,
that's true.
I think it's important for our clinicians who are listening in and also our patients listening in that early treatment does not necessarily mean early treatment with high cost medications.
Yeah.
And there is a stepwise approach to these medications. And there are indications and reasons as to why these decisions are made at a national level yes, I agree with you that as a clinician should apply pressure on, but there is a wider picture of where we sit as a specialty, and where some of these drugs, like, the medications do go through what we call the drug cycle, where certain medications do at some point become more readily accessible. So I do agree with you, Margot, that in the future, I think the management of nodular prurigo will be more exciting when some cost of these medications will go down and may become more accessible for our patients who are asking for more targeted treatments and more for the future. But also on the lines of personalized treatments, I do meet patients who do want the longer term safety data. Is this going to cause harm in 20 years down the road? And I do say hand on heart, I cannot tell you the 20-year safety profile. I can tell you the 5-year, 10-year profile of medications like dupilumab and maybe the 5-year data of nemolizumab. Um, but time, and we're seeing that with a lot of these new medications that are coming through, very exciting medications. Main one we talk about is also GLP-1 agonists. Again, we don't know the long-term safety profile of some of these medications, but these are all very exciting and very safe medications to the extent of our knowledge at this moment in time. So I do also
It's
want to,
approved
because sorry?
and just a comment, it's specifically approved for this condition. So all the medications like
It is licensed and
methotrexate are
approved,
used
but not in.
off-label.
Yeah, so but it is not off-label, but it does put we do have to think about some services in some areas where they're not able to
No,
offer
we
this
agree.
for
We
their
completely
medication.
agree. And that's why
And
we
it
have the
yeah.
step approach. We are not
So
offering everything to everyone.
yeah. So on that note, I do just because we're coming towards a close, there is one question that I do want to target for because some patients do come in with natural anti-itch creams. What are our thoughts on natural remedies for patients, and are they more effective than prescription treatments? We'll start with Margot, then Hannah, and then I'll
Okay.
close us off as the final
So
question.
the word natural, I think, sometimes, it's quite, how should I say, it has a double meaning there, actually. So many patients, when they are reading something that says natural, they feel much more at ease. They feel that it has a better safety profile. And they're using many of these, topical treatments over the counter that they buy. And they believe that they may be using something that is very, very safe. Nevertheless, the reality is that, in medicine, we practice evidence-based medicine. We need robust data about what is inside these natural creams. What we are seeing is that many of these natural creams also contain topical steroids that are not on the label, or they can be on the label, but they are with very, very small lines. So actually, some of our patients may be using natural creams that contains topical steroids in it without knowing it. And this can be a significant risk for the patient in long term by using them long term. So I think, again, we need to raise awareness about these natural products. We need to inform people what are the evidence-based potential treatments. And also, we should all have a bit more critical approach to these natural remedies, because the majority of them, they have not been tested. All the medications that we are using, they have undergone through so many different clinical trials. We have robust real-world evidence. We have been using them, for a period of time. So many of these natural products, they have never been tested, actually. So I would take everything with a pinch of salt, I would say. And that's something that I explain to all my patients, because there are so many advertisements out there, online. There are shops that are actually selling products like this. So raise awareness.
Hannah?
I echo Margot's sort of thoughts regarding evidence-based medicine. I think sort of a natural remedy can mean lots of things, and I think I have to carefully inspect what they're using. But I certainly completely echo her sort of statements about sort of evidence-based medicine and the importance of that in our clinical practice.
Yeah.
And also we should, sorry.
Sorry, yeah, I'm just very aware that we're coming towards 11:30, towards the end of our session. So I think the general vibe is, natural does not necessarily mean safer. But I think if I think it's a word of caution that if you are using natural-based products, it is worthwhile perhaps bringing them to your dermatologist at your next appointment so that we can see what you're using. Because I do think I completely agree. I think yes, whilst we don't have trial studies to confirm some of these are being effective in the management of itch, I think using a do no harm, as long as it's not harmful, they're not steroid containing. Some of our patients do prefer more natural-based remedies, and I think bringing them to our consultation will allow and facilitate further conversations around, okay, what can we offer that's complementary to the natural remedy in our clinic space. And on that note, given that it's 11:30, we will come to an end with the UK's agenda for the World Prurigo Day. Following up, I think, is France. So we'll hand over the baton in this Olympiad of world events, and we'll pass on to France, who will be hosting the next round of activities in the World Prurigo Day. We thank you for your time, and we hope you have a wonderful day. Thank you to our speakers
Thank you
today
very
too.
much.
Thank you.
Have a
Bye-bye.
lovely day. Thank you.
Bye-bye.